residency in neurosurgery at the University of Oklahoma, fellowships in spinal deformity and reconstructive surgery at the University of Virginia, neurosurgery spine service at the Medical College of Wisconsin. He's specialized training in surgical interventions related to spinal deformities, scoliosis in adults, pediatric patients, and is trained in minimally invasive spine surgery. Dr. Alexander completed medical education at the University of Illinois, with residency in neurological surgery at the University of Louisville. He has extensive expertise in surgical and non-surgical treatment of brain and spinal cord disorders. Nikki Ziegler completed her BSN at UW-Madison and her MSN at Concordia University. She's board certified as a family practice nurse practitioner and has worked down at Freighter Medical College in the neurosurgery department before joining the neuroscience group.
Thanks for having me. I appreciate you coming today. Today I'm going to talk about pressure fractures and thoracic and lumbar spine. Typically see.
You guys already lost it. You guys already lost it. I was reading about it.
It works at least.
Good, how are you? Good.
Okay, very good. All right, well, very interesting start. Okay. First of all, I just want to talk about fractures themselves here. When we're looking at compression fractures, we have to know how the spinal vertebral column is divided. Normally, there's an anterior column, a middle column, and a posterior column. The anterior column is the anterior half of the vertebral body. Posterior half of the vertebral body would be the middle column, and the posterior elements would be your posterior column. A simple compression fracture typically just involves the anterior column. It can slightly involve the middle column. And usually these are flexion injuries here, depending forward when it happens. The second type of compression fracture would be a burst fracture. Usually involves the anterior middle columns. This is an axial loading injury here, so pressure is coming down, crushing the body. Causes, by far the most common cause, it would be trauma. You can have osteoporotic fractures and even sneezes and things can cause a fractured bone in those patients that have more severe osteoporosis. And then pathologic fractures, those would be things like cancer. Multiple myeloma would be one of the more common ones that you'll see. Obviously, metastatic lung cancer and things like that, and also plus pathologic fractures as well. Clinical symptoms, the most common thing would be pain with activity. Those with more severe fractures, such as a burst fracture, they're going to be lying in the emergency room, not wanting to move at all. Any type of movement brings a lot of pain in their lower back or in their back. And those with osteoporotic fractures, it's always amazing because you walk in the room seeing them, and they usually look like they're in no pain when they're sitting in the chair. It's only when they're up and moving around, you ask them to walk down the hall, they're like, no way, that hurts too much here to do. So that would be the most common, one of the more common symptoms. Obviously, you have tenderness around the fracture site, palpation of the lumbar spine or thoracic spine. You can have various, for more severe fractures, you can have various neurologic deficits, either sensory deficits, motor deficits, of bowel bladder dysfunction, especially if it involves the conus. Obviously, imaging, plain X-ray studies can identify these. CT scans is a little more detailed than MRI, obviously, do a little more detail as well. Bone scans you rarely use for these, except that they can have MRIs. We can talk a little bit more about osteoporotic fractures and use of bone scans in selected patients later. Signs of an unstable compression fracture, typically greater than 50% height reduction, neurologic deficits of any sort. And if there's a neural impingement, you want to surgically decompress that. Progressive kyphosis on repeat imaging, it continues to fracture down and get more angulated. That's something you probably want to try to deal with either surgically. Evidence of, obviously any evidence of ligamentous injury on MRIs is important. Posterior elements may be attacked, but if there's a lot of posterior ligamentous injury, it may cause a subluxation of that needs to be fused. Signs of an unstable burst fracture, neurologic deficits of any sort, you would want to go ahead and do a surgical decompression of that. Angular deformity greater than or equal to 20% is typically considered more unstable and need surgery. Spinal canal diameter reduced by 50% or more, or 50% or more compression of the fracture. And most of the ones that we see in trauma are usually pretty bad. They're usually 50% or more. Traumatic fracture treatments for stable compression and burst fractures of thoracic lumbar spine usually are treated with bracing in someone who's not osteoporotic. The upper thoracic spine, you may use devices such as a Minerva brace, which is kind of a chest piece and an area that basically some stability to the chin and the neck. CME braces, again, similar. It's a chest piece with a chin piece to there, and some stabilization of the posterior part of the neck as well. Mid to lower thoracic or lumbar spine, you probably would use a TLSO brace for a stable type of fracture. If it's combined, you might use TLSO with a solar extension and extend in the neck. Aspen makes some devices where you get a cervical collar connected to a thoracic and say rotophosis, so that can be done as well. So there's various options for you. Unstable compression of burst fractures are typically require surgery. These can be usually either posterior or combined anterior-posterior fusions, typically. I guess you could go anteriorly and brace, so you can cater it to each individual patient what you feel is necessary. This is a case that I have. 71-year-old male. He was in an auto race over at the track in Oshkosh. He was driving his Porsche about 100 miles an hour. I guess there was an accident in front of him. He slammed into the car in front of him. Immediately, he had low back pain at the scene and was brought over to David Clark Hospital for care. On his neurologic examination, he was completely intact. On his imaging study, he had a L1 burst fracture. There was some severe stenosis, as described by the radiologist, and there was also a spinal epidural hematoma. This is the CT scan here. You can see here, this is here you're looking at the height of a regular vertebral body. You can see the vertebral body here on the CT scan is probably about half the size or less of the vertebral bodies above and below it. You can see there's a fracture fragment really constricted now, probably about 50% or maybe a little more. This is an MRI that was taken on the same individual. This is kind of at the midline. You can see it's kind of pushing the conus posteriorly. Again, you have a fracture of significant amount, more than 50%. So if you were to stand up, you'd be concerned about this collapsing down and pushing more bone fragments back toward his conus, causing paralysis. So this is one we treated surgically. This was a anterior-posterior type of fusion. Here, got a lot of height back too, but this is an anterior plate here. You can't really see the construct from this angle. We'll see the inner body construct, which we did a thoracotomy anteriorly, got all this bone away from the spinal cord itself. Selected an inner body graft, packed it in the bone, that we collected from here. This is for anterior stabilization. And then we kind of flipped him over on his back, did a posterior stabilization here. These are screws going in the pedicles of the vertebral body above and below, and posterior stabilizing rods here. So that would be an example Usually if you were to do something like this posteriorly, say 2 or 3 above, levels above, you would need a fuse. So this is nice that you only have to fuse a couple of levels here, where in the past, before good anterior instrumentation, you didn't have that option. This is the anterior view period, anterior posterior. This is the unibody cage right here. It might be a little blurry here on this. These are pedicle screws here and here, rods, and these are screws going into the retriever body as well. Osteoporotic fractures are something that we would commonly see in the office here. Lifelong risk of these fractures can be fairly high, so up to 60% of all women will have a symptomatic osteoporotic fracture in their lifetime. Approximately 5% of men would have a symptomatic osteoporotic fracture in their lifetime. Osteoporotic fractures are significant in that even though they can heal on their own, people can get deformity over time, kyphotic deformity. You continue to lean forward. You see these old people lean forward quite a bit in their practice as they get more, in your practices as they get more fractures adding up. This can lead to chronic pain. Obviously, if you're kind of hunched forward, you can't fill your lungs as well. So obviously, decreased lung function can be a problem. Impaired activity, obviously balance is a problem. It's hard to eat a big meal when you're kind of leaning forward like that too. You can get gastric distress, reflux disease, other problems. So this can be a problem if you have numerous fractures over time. Obviously, as the balance gets off, it kind of puts more stress on some of the bones below it, so you're more likely to get future fractures at other bones in the future. Obviously, with all the things added up, there's increased mortality over time, which is not surprising. Imaging diagnosis, MRI is typically what we would get to assess for an acute fracture versus a non-acute fracture. You can also, often on standard T2 images, you can't really see any difference on any fracture. You have to look at T2 stir images or other images to identify an acute fracture for this. Obviously, you can see these on plain films in your office, or if there's any changes from prior films, or a CT scan could also give you some information too as well of the acute fracture. If you're unable to get an MRI due to a pacemaker or metal tip or metal in the back or something, you might have a metal fragment in their eye or something. You would preferably get a CT scan plus add a bone scan just to make sure that it's an acute area of inflammation. This is an example of a T2 image here. I don't know how well it shows up, but here's an old fracture here, and the new fracture is up here. You can't even see a difference. Here it kind of will line up on a T2 weighted stir image. Here you don't see the old fracture down here around 212, you don't even see. This is an example of an acute fracture on T1, on a T1 image. It's a little darker, so I have it, a little bit hypo-intense there instead of hyper-intense. And the one at T12, this old wedge-shaped fracture you can see down here, doesn't show any darkening at all. So with osteoporotic fracture, the initial treatment typically is pain medication for control. If you were to see these, you can just give them some pain medication if if the pain isn't too severe, and we can see them as an outpatient and decide how to treat these folks. Usually bracing is extremely poorly tolerated in these individuals. I think it's just as far as compliance in older folks, it's just really hard to get them to wear a TLSO brace. Also, with their deformities adding up over time, it's very hard to fit them in anything appropriate. So usually all you're doing is pain medication control for these folks. Obviously, you have folks that may be in so much pain, you have no choice but to hospitalize them, give them IV medication, pain control for this. Your treatment options include, if their pain is under reasonable control with pain medications, you can just follow them over time, especially if the deformity isn't too bad. you would just watch these folks, and we've had patients in my practice here, that we would just watch over time, and they get complete pain relief. Obviously, you follow-up imaging studies if you see further angulation or progression of the fracture. You would probably want to treat these procedurally. Balloon kyphoplasty is the typical surgical procedure for this. If you were to try to treat osteoporotic fractures with instrumentation, they would have major complications, screw pull-out, et cetera, et cetera. So open surgery is really almost never indicated for these individuals as far as stabilization is concerned. This is an example of a kyphoplasty here. First of all, when we're looking at balloon kyphoplasty, it's a percutaneous procedure. So it's just two little needle sticks on each side of the spine here. We thread a needle through the pedicles on each side into the vertebra and drill into the vertebral body. There's a balloon that's placed within the vertebral body and then expanded using a radiopaque dye. This is not a fractured segment. This is just an example of a catheter balloon here within the vertebral body. The inflation of the balloon is hopefully reduces restores the height restores the height of the vertebral body. And then after the balloon is deflated, you place a bone cement. And there's various bone cements on the market here. There's at least a few different systems on the market for balloon kyphoplasties, and they've been out for a long time. Initial treatments for this would be a vertebroplasty where they just stuck cement in. Almost no one does that anymore. They weren't as effective as a balloon kyphoplasty had because there's no restoration of height with that. So pretty much everyone who does these does balloon kyphoplasties, not vertebroplasties any longer. Complications for these are really quite rare. In some of the studies, it's like 0.3% at most. Typically, those things would be infections of the cement. That would be extremely rare. Extravasation of the cement is extremely rare too, because you do this under fluoroscopy, so as you're injecting the cement, you know exactly where it's going here. I guess theoretically, if you don't know what you're doing, you could get into the wrong area. You could stick a needle in the spinal cord, I guess, or stick it in a nerve root or something if you're not being careful, making sure those trocars are going through, needles are going through the pedicles. You can also, if you poke the dura, you can get a spinal fluid leak. Hemorrhages are always possible, and various anesthesia complications, allergies to anesthesia, etc. Again, all those added together are extremely small. Contraindications, heel fractures. If it's a heel fracture, you won't be able to inflate the balloon or really put any cement into the bone. So if it's a heel fracture, it's completely contraindicated. So if you see something on older scans that you don't see the T2 stir images showing basically hyperintensity, then that would be an old fracture. If they're concurrently have infections, obviously you don't want to be doing surgical procedures on people with active infections here. Instability, they would need to instrumented fusion for. If they have focal neurologic deficits, there's usually a fragment disc herniation, something else that's causing the problem, and so you would want to do an open procedure to decompress the spinal cord nerves. And posterior vertebral body destruction, obviously if you're injecting cement there, that could extravasate into against the nerve roots or against the spinal cord. And if they have a gross coagulopathy, you don't want to be doing this here, otherwise you're just going to cause an epidural hematoma or other bleeding. This is another case. This was a 75-year-old female with a history of osteoporosis, known history of osteoporosis. She was admitted to the hospital after a fall at home with severe back pain. She describes the event that she was standing on her toilet, putting a vase up in a cabinet. She lost balance, tried to grab one of the towel racks. It stopped her fall somewhat, but She probably fell from the height of about maybe 3 feet where her butt landed on the floor. So not a big injury. Most of us would just be embarrassed, but obviously for a person with osteoporosis, that's enough to give them a fracture. Her neurologic examination was intact. The imaging still showed the L1 anterior acute anterior compression fracture. And this is the CT scan here. This looks like about a 25% height reduction here. It's involving mainly the anterior part of the vertebral body. The posterior element, part of the vertebral body is completely intact. Now, obviously, if we're a patient in severe pain here, this would be someone, in order to, they're not getting good relief with the narcotics, you can't get them off. Obviously, this is a good candidate for a balloon kyphoplasty. So what we did was a L1 balloon kyphoplasty. She did extremely well. 2 weeks postoperatively, patient was experiencing no pain whatsoever. She had resumed normal activity. So it's that dramatic here. This is a lateral X-ray. This is all the bone cement kind of filling the vertebral body. We got a little bit of height increase. I would say that's getting closer to normal. This is an anterior posterior view. You can see the cement is kind of filling the vertebral body there. Pathologic fractures, I want to say just a couple of things here. Typically, the kyphoplasty has been done for multiple myeloma. Multiple myeloma affects every bone in the body here, so it's very similar to an osteoporotic fracture in that way. So typically, we're to see a fracture, if you were to look at our literature, it'd be like, don't touch these things. These things kind of get better with time with chemotherapy and or radiation if necessary here. Though they have started doing these if there's severe pain, which you need to deal with, kyphoplasty would be something to consider for those patients. Obviously, you have to remember the contraindications for this here. One example I remember was a cervical patient who had multiple myeloma, where it almost looked like there was a bite out of the anterior part of the vertebral body. It was around C6 or C7 here. I remember they went to another hospital, I think they have been running a clinic for this, and they wanted to do a kyphoplasty on that. Well, that's totally off-label here for something like that. There's nothing holding that bone anteriorly if there's a big bite out of the vertebral body here. There could be major swallowing issues, which you can get into a cervical spine compared to a lumbar or thoracic spine here if you have a big wad of cement sitting there. So I actually, it was interesting because I actually told I wouldn't do that and followed him out. He's now years and years later. And it just usually forms scar tissue, fill up and is very stable thing. So it looks awful on the scan, but it's extremely stable healing for those. So it's amazing that sometimes what you read in the book is actually right, even if it looks frightening. I remember even a family member just met me again regarding this patient, was like, thank you for not pushing toward that, because they would have gone through a lot of unnecessary treatment. So, like I said, contraindications need to be thought of when you're dealing with this. Not everybody needs to have a procedure done on that. So, that's the end of my talk here. Hopefully it didn't take excessively long. These are the kids eating lunch. So, any questions? Or I'll let Dr. Bhattacharya take over here. And again, I'm Dr. Hawkins. Thank you.
Can you guys hear me okay? I can hear myself very well. So getting started with the management of adult spinal deformity, as you can see, most of the theme is, and this has been a trend essentially in spine surgery, population in the United States are getting older and older, and we're facing these sort of very complex problems, and those days are behind us. You know, when I was in residency, I would just tell them, oh, you got a bad problem, just go home and live out the few last years you have. And That's it, you know what I mean? We don't have a whole lot of solution for you. But the populations is going to continue to get older. We need to come up with some more innovative solutions to do it. Said that, I don't, you know, some of the issues dealing with these spines are already covered by Dr. Hawkins. So, you know, the kind of osteoporotic issues, degenerative issues that every population experiences. But this is also a growing problem in the population. 12 million adults will have some level of deformity. That was in 1990. That is up to 47.7 million people. Really, the significant issue is much more smaller percentage of patients that we deal with. That's where I come into play at times. It's about 500,000 people, and probably going to be 1 million at the end of this decade. And this is continuing to be projected to rise as we head towards, you know, towards the end of this millennium. And we need to have better solutions. Interestingly, tremendous attention has been paid to this. And we're trying to understand this best we can and some of the solutions that we can have for these patients. So the real key issue is to consider is the degenerative de novo scoliosis. These are not same as an adolescent idiopathic scoliosis patient. These are patients who are developing these problems de novo. They didn't have scoliosis as we age. Our facet joints erode or decay in a different rate. Our disc decay in a different rate, leading to the degenerative deformity formation. We can always thank our predecessors, including myself in this group, where we have created some of these problems with doing surgeries that we thought we were going to be helpful, but over the years we have learned that may not be the helpful. One of the things is the Harrington distraction drug. It's a great treatment for scoliosis, but it creates some adjunct problem like creating flat back deformity and other things, which are very complex deformity for adult and older patients as as they go through the ages to the degenerative changes that take place. So we see multiple different areas where these sort of deformity over time, as with aging, becomes a big issue to deal with. Again, other, like osteoporotic fracture, one of the component of it you have to see that granted these are very osteoporotic patients, but in a small subset of those populations, they can have sport compression myelopathy. Then what do you do? Now we're talking about a much more complex issue. I had a slide here, I took it out, where essentially a compression fracture with 90-degree kyphotic angulation. This patient cannot move their leg for compression, and they're looking straight at the floor, literally 90 degrees on the CT scan. It would have been a good adjunct to follow. So this is an example of a degenerative scoliosis patient. This patient never had scoliosis development. Interesting point to watch, wires in the chest wall. You know what I mean? So clearly multiple medical comorbidities. How do we do this? How do we manage this patient? Similar problem, different age groups. So this is a wide spectrum of patients who are adults who are presenting with these deformities. And this is, again, a patient that has spondylolisthesis that was untreated, and over time, they're developing much more complex issues. Again, this is an example of what we alluded to previously. Look at that rod. Our spine is not meant to look like a straight rod. You know what I mean? They have natural curvatures. We have not obeyed those principles, and this is how our spine looks. Now, granted, this was great treatment 30, 40 years ago, but we are kind of reaping the consequences of it as time has gone on. So the natural history is very important to see who are the patients that we will end up treating. Let's look at idiopathic scoliosis. Why do we operate on scoliosis patients when they're younger? Because there is this natural history. That number that we pick, 50 degrees, is not out of the blue. What time has shown us, if you're an adolescent with a 50-degree curve or a 45-degree curve in the lumbar spine, 40 degrees, somewhere around there, you're going to have substantial progression with degeneration as you get older. Is there a huge advantage of correcting it sooner? There are some advantages: healing, recovery, functional status for the years that you're having pain and suffering. So there are advantages to treating them at an earlier age, and because of the degenerative changes that are to follow. Again, this is a history of another patient. 28-year-old is a patient of mine. And I will address look at the side view. This patient has developed almost a straight, flat back as she has degenerated the lumbar spine, and she's only 28 years old. So when this patient is 40 or 50, this is a much more complex problem to treat and address than what it was when she was an adolescent, when this was not addressed. But the biggest concern is this population of patients where this is a degeneration of the spine that is taking place, and some of the deformity are essentially a compensatory mechanism that leads to overall, feeding sort of the fire and more more compensatory mechanism comes in, they become decompensated, develop stenosis. So this is a cascade of events that are starting to take place. On top of that, you add the aspect of osteoporosis, so you have created a very complex set of problems for these individuals. One thing we have to understand that this is not a question of low back pain. We get very excited, and I'll show you the future slides, when we see a very curvy spine, or they have more back pain. I have 50, 60 degree curve patients comes in. I'm doing fine, just want to make sure where my curve is. Okay. So the scoliosis inherently, you know what I mean, is not a source of pain. It's what the neuronal aspect is that is causing. That doesn't mean everybody is the same. There's a person in your patients who develop the back pain that comes along with it. But the key component of it is the neural compression and the neural issues that comes in as the deformity worsens and the stenosis worsens over a period of time. So again, and we see that in the evidence because higher incidence of radiculopathy and neurogenic claudication that we start to see in these patients. Again, the lumbar curves are more prominent, and they are, you know, the majority of the patients who are older that we deal with that causes much more pain and discomfort, more stenosis, more difficulty with their gait, and so on and so forth. There are multiple radiographic factors, I'm not going to bore you with that we look for, that we know there is some correlation to their symptoms. This is, you know, this is an older study. Now there are a much more robust study that confirms those sort of things. There's more than 1,000, 1,500 patients, where there's a very good correlation between the deformity and some of the signs and symptoms that we see. Again, these are discussing the same radiographic parameters. This is probably the most important slide, you know, that we will talk about. That one of the things that we have found over the years, and this has been very strongly proven now, and a lot of them came from the iatrogenic studies of Harrington, the issue of sagittal imbalance. When a person is leaning forward, these are the elderly patients that are walking into your clinic, who are leaning forward, have pain, they have a lot of decompensation. These are the most suffering patients. This is a true correlation between back pain and leg pain that we can say there's a one-to-one correlation. So the higher the sagittal imbalance is, the more leaning forward they are. There's a linear relationship with the morbidity they have. They actually have newer studies that they have looked at cardiac morbidity, you know, patients who have, you know, ejection fraction of 20, 30%, and they have looked at the severe sagittal imbalance stenotic patient. They're pretty comparable how their functional status is and how significantly ill these individuals are. So this is a huge burden on the individuals as far as illness goes. We never correlate cardiac disease to lumbar stenosis, but the amount of functionality increase they have is substantial. And you know, you can compare to a person who cannot get up and move across the hall to go, you know, go to the bathroom because they're short of breath. These are the patients, some of them are suffering in the same degree that they are unable to function at a normal level. So it is probably one of the key issues that we pay attention to while we are treating these problems. Again, sagittal plane balance, all these balance issues are very important. And there's enough studies done that, you know, has been a very strong correlation. The greater the imbalance is, the longer and the more dramatic the problems they've experienced. Truncal imbalance is another aspect of it where they're kind of listing or shifting one day. Again, this is not as strong of a correlation to morbidity of a patient than the sagittal imbalance is. So again, the curve may look incredible and we are very concerned about it, but it's not the biggest thing. Treatment options, clearly non-operative treatment should be entertained first and more than anything else. You know, physical therapy, water aerobics, I think transforaminal injection is a key component of this treatment because it specifies the nerve root and the specific problems they're experiencing that we can find a solution. Again, weight loss, I know all the other good stuff that we tell our patients to do in order to accomplish those goals. Again, I'm getting into the surgical aspect of it. Me being a surgeon, this is how we address. This is a very small subset of population that we see, but nonetheless, these are much more complex people. These are the people with the most disease burden, as we can say, who comes to see us. Our primary goal is to reverse neurological issues, get some pain relief, establish a global balance. We want to preserve motion segments when we do that so they're more mobile, they're not stiff and solid like a rock, and minimize complications while we accomplish this goal. But at the end of the day, if this is your outcome, you want to do Pilates or yogas and bend 360 degrees, we're not going to accomplish that. So we have to have more realistic goals, what we can accomplish. Our goal is to get the patient, get up and walk and perform day-to-day normal function. This is, so a person who's not significantly morbidly diseased, we do not recommend any surgical intervention because the toll of surgery is substantial. Again, these are, again, the nuances of, why we operate on them and some of the issues we already touched on. So surgical approach could be simple decompression on the right patient versus very complex osteotomy doing multi-level surgery. There's a role for minimally invasive surgery that we can talk about, but most of the time, we try to do, if there's a substantial deformity of global following, address the global issue. There is room for limited surgery for these patients who have a fairly hyperstable spine. They're so, or they're so osteoporotic that they would not tolerate instrument infusion, but they have severe leg pain. Then we can focus our treatment and do a limited intervention of these patients. Again, this is another example of degenerative scoliosis. One of the things that we want to point out is severe number of nerve root compression. There's no way to get this better by doing, you can do physical therapy until the cows come home, but this is not going away. And this is what requires surgical intervention because the morbidity from that is the limited mobility they have is tremendous for some patient populations. Again, sometimes it's a good idea to do this is an honest effort to do something cute and simple, but over time this turned out to be a bigger and much more dramatic problem. Again, minimally invasive surgery, as we alluded to, in a solid subset of patients where we can do a limited operation with the least amount of disruption is a good idea. Again, patient selection will be a critical aspect of it. Again, this is again an idea about trying to do something small or simple kind of becomes this cascade of multiple surgeries that over the years keeps adding, where the index surgery probably was not really thought out. The disability index, that we look for, there is a substantial improvement in that. There's a 54% improvement of the disability index. If you look at, and this is some of the things, if you look at from the coronary artery bypass, and these studies are coming up because these are expensive intervention as far as instrumentation goes. So a lot of these things are how many life years we are saving for these patients, and the correlations are very strong and robust. That significant cardiac disease improvement that comes from our cabbage. Sometimes we see that many life years expectancy improve on these patients with these operations. So there is reasonable data to suggest that all is not in vain. We're just not doing this to make fancy X-rays. Again, SF36 decides the same. So the concern is what we are trying to improve upon. Over time we have noticed these operations do have some increased surgical complications. Our goals and efforts are to minimize those complications risk is about 10 to 20%. And try to get better outcomes. Again, patient selections also plays a role in this patient. Again, over time, we're going to try to improve our overall outcome and see, conservative care long term is not a good answer, and surgical intervention tend to give a better results for the long term with these patients. Again, patient selection is key on all these studies. So these are some of the strategies we are using in order to minimize complication risk on these older patients. We're very particular about who we select and who we are doing the operation on, and being very vigilant about doing the operative intervention. We minimize morbidity, neurological deficit by monitoring these patients, nutritionally planning them very well preoperatively and postoperatively, and obviously planning the surgery as diligently as possible. To end this, I just wanted to show this X-ray before we leave. This is a patient who had degenerative scoliosis, had originally scoliosis, had degenerative scoliosis over the years, progressively got worse. As you can see, has a valve replacement, has open chest surgery, has a neck operation. The valve replacement was done by Dr. Lilly, and after she got back, after a year later, I told Dr. Lilly to stand outside the door while we did her operation over here, and we, in a stage fashion, were able to fix the patient. So she's much more functional, much more active, but as you can see, this is an extensive intervention for any individual to go through, and these patients have multiple comorbidities, so we have to be careful who we select and who we operate on. Patient satisfaction is great if they were to get through the surgery well and alive. It's a demanding surgical procedure for every individual included.